pleased to have Dr. Diego Barrieras with us today. Dr. Barrieras has been a urologist at CHU Saint-Justine and CHUM for over 20 years. He's a super specialist in pediatric urology, having trained at the University of Montreal and the University of Toronto. He has a strong interest in urinary tract reconstruction and neurobladders, transitional urology, and kidney transplantation. In addition to his role as a professor at the University of Montreal, he and his collaborators have published and presented more than 60 scientific papers. Dr. Barrieras will speak to us today about transitional urology and spina bifida and the management of constipation, and the objectives of his presentation are to know the issues around follow-up and of neurogenic bladders for adults, awareness of the short and long-term risks of kidney function, to know the problems related to stool elimination, become familiar with the pathophysiology of stool elimination problems, know the pharmacological therapeutic approaches to stool elimination. Dr. Barriers, the floor is yours. Thank you. I'm happy to be presenting for everyone about transitional urology. It's a topic on which I've been working for a long time. When I started in Montreal, in Quebec, there wasn't really any platforms to transition patients from the pediatric world to the adult world. And often, even if it didn't exist yet, patients were found between two spaces with long times without follow-ups and care. And that was true for patients with spina bifida, but also with other congenital and neurological malformations, which are my specialty. So I'll tell you about that with an emphasis on constipation. I'm not a gastroenterologist, but in neurology, we have to manage elimination problems of urine and stool, and the physiopathology is similar, and the care is often done by urologists who also have an interest in elimination, stool elimination issues. And we speak to super specialists when with the basic treatment we don't have the resources to treat certain things. The objectives were presented already, so conflict of interest. I am a principal investigator for Allergan, as are my partners. Here is a picture of Saint-Justine Hospital. Some of you probably know it. It was enlarged recently. It has now become one of the biggest mother-child centers of the Americas, and we are very proud. And here is the CHUM, which is even newer than Saint-Justine, and it is one of the biggest hospitals in North America as well. So a lot of our patients go from Saint-Justine to CHUM, and that's where we follow them to. On this page, it's to show that there are many scientific papers and documents about transitional neurology, and it's true of other specialties. It's a subject that wasn't studied much in the past, but it's better known now with all the issues that we will mention today in the next slides. So, what is transition? It's going from the pediatric world to the adult world. It's defined as the ability of a person to take charge of their health of independently, to have a better and central role in decision, being as independent as possible from parents, and the pediatric structure, of course, with all definitions patients. It doesn't include really everyone in all situations, but this is the essence of the idea that we had a child that was taken care of since birth for most patients with neural tube anomalies, and for all their childhood, they had a medical team, a multidisciplinary team, and their parents that made most decisions for them and would take many precautions. But now, this person, we give them the decisional power on their health and what they want to do. So we make them independent. And it's not always easy when someone has always been a bit dependent of a structure. So becoming independent is not always hard just for the patient, but also for the teams to succeed in doing this transition and giving more responsibilities to the patient. Below, you have a different definition from the American Academy of Pediatrics and family physicians. It says more or less the same things I just mentioned. So the transition from pediatric age to adulthood has been a problem for a long time, long-standing problem. It's linked to improving overall care. In the 60s, 70s, patients with anomalies of the neural tube, the more serious pathologies, and more physical disabilities and intestinal issues did not have the same life expectancy as they have now in 2022. So it was a problem that did not have the same importance because, unfortunately, people did not have the same life expectancy. But now, with Spina Bifida, in the past we could compare it with cystic fibrosis that had a very short lifespan, and now it's longer. So this has caused problems for teams taking care of adults because they didn't necessarily have experience or expertise on the question. But today, almost all children with all spectrums of spina bifida will move to the adult world. It's very rare that there are serious complications and they don't make it to adulthood. So I won't go over this in detail. It's in English. It's an article that was published just last year. But you have everything that's involved in transition in the point of view of the patient, but also the point of view of doctors and treating teams and families. What makes it difficult? In general, there's a big link that is developed sometimes between even before birth when they received a diagnosis until adulthood. There's a strong link with the medical team, with the parents, the doctors, the therapeutic team, urology, the orthopedics, neurosurgery. There's physiotherapists, a pediatric doctor. So there's this whole team that sees the patient on a regular basis and takes care of all the aspects of the children's health. So there's a very strong confidence link. So it's hard to think that you have to find a team with which you'll have the same link. So it makes this transition difficult. And we're all the same. When there's change in our lives, whatever area of our lives, it creates anxiety. So that's part of what makes it difficult as well. And also the lack of information of what's available, the resources that are available, where to go, when we make this transition. It was often nebulous, and patients didn't know where to call. Do I call my doctor? Which clinic, which hospital do I have to call? Who's going to take care of me? So just this was a challenge. So all this, course, causes anxiety, but also makes patients more vulnerable to complications and problems with mental health.
à devenir évident qu'on aurait des patients
When it became
pédiatriques
evident that we would have a lot of pediatric patients who would become adults and needed to take care of it, it actually created quite a lot of issues. The resources and investments as far as chronic disease are actually very poor still. We have been talking about these things on TV, and the resources outside the hospital are quite limited, and it varies from country to country. But globally, we invest a lot of money in acute diseases, but not as much effort in chronic diseases, and very often how these diseases bring people to the hospital, and we could avoid this. So there's a mentality that we would need to change as far as chronic disease is concerned. Of course, there's a lack of expertise. I've talked about it earlier. There are not many urologists, urologists who have uh, developed training. I have the opportunity to work with Dr. Jolivet. She has training in neurological bladder, and it includes Spina Bifida. And over the years, she's been working with me at Saint Justine, so she gets to know the patients before they get to adulthood. So it really helps the transition. And also before, even if it's less a problem now, there was a lack of communication between children's hospitals and adult hospitals, because the Canadian system, everything stops at 18 years old. And so there was a rupture in the services between the organization. Here at Saint Justine, we've had a pretty liberal approach. So we've had patients who were 19, 20, 21. So we were stretching the pediatric stay. So of course there were some inconvenience because it's not a hospital that's thought and designed for adults, but it did help with the transition and the transition to adult care. Another thing that was problematic is that kids are different from adults, and the management or is different. As a clinician, we take care of kids a little bit as though they were our kids. So we're adding up to the parents as far as how we do things in our considerations, and the psycho social aspect that is heavier in pediatrics than it is in the adult world. There are pros and cons to this, actually, because when we manage in a more holistic and intense way, sometimes it does hinder autonomy for a patient who can actually do their thing by themselves. So we need to take this into consideration in pediatrics. So now, what are the consequences of having a bad transition? There are several studies that have shown that the patients that haven't been well taken care of or sometimes not taken care of between two worlds, and they can have complications, and they can uh, come more often to the hospitals and to the emergency room. And at the emergency, we take care of acute problems, but not all the problems. And very often these patients need care of different specialties. So because of this, there are more surgeries that are being done uh, because of complications. We've seen that 56% of patients have required a surgery during this transition period. Sometimes there's a kidney failure because the there can be also a loss of bladder and bowel control, fertility disorder, a loss of autonomy, and social isolation as well. And so some people can isolate themselves when they're not taken care of properly. What are the solutions now? Actually, there are solutions, even if it seems like it's a quite difficult picture. People organize themselves. There's the neurological bladder has not changed very much in 100 years. There's a principle that we were evoking 100 years ago: optimize bladder emptying, reduce the risk of infection, protect the upper urinary tract, prevent, recognize, and treat the complications before they become irreversible. These are all principles that were actually put forward more than 100 years ago. I put the reference uh, at the bottom, and what we do in 2022, it's actually quite close. We maintain the renal function. There are vesicle problems also, and other problems that Spina Bifida patients have, and we want to avoid dialysis. And we also want to improve the quality of life by maintaining optimal urinary and fecal continence. And this definition comes from the patient. What is an adequate bladder and bowel empty? Sorry, what is something that is suitable for the patient? We have to ensure adequate bladder and bowel emptying, take care of problems linked to sexuality and fertility. Now there's a life expectancy that's much better than before. So these are things that the patients are looking at and asking themselves about. And in the past, it was not so much the case, but now fertility is part of people who have a spina bifida, and we can really go around these problems. So we tackle this problem more. Also, we regularly monitor possible changes in function in order to treat adequately and avoid complications. And also, in the past, we used to think that kids with neural tube disorder, they were stable and their state was chronic. But unfortunately, we age, and with aging, maybe it's not just aging, but there are some anomalies as far as how the bladder functions and the digestive tube. So the changes can happen. So we need to monitor and really follow up in a regular way to avoid surprises. Sometimes we can prevent surgeries if we have a good follow-up with patients.
Bon, le modèle du CHUM et de
Now,
l'hôpital Saint-Justine, en fait,
the
ça
model
a
of the
commencé
CHUM and the Saint
quand
Justine
j'ai commencé
Hospital, actually, it
des cliniques
started
de
when
suivi
I
adult.
started doing follow-up
Plusieurs
clinic
années,
with adults a few years
début des
ago.
années 2000,
At
mes
beginning of the
professeurs
year 2000,
voyaient
one of my
par
teachers,
l'installation du CHUM
professors who
dans
was
le nouvel hôpital,
working in the older version of the
demandé
CHUM,
serais-tu intéressé de faire
he came up to me
un
and
tour
says,
de
would you be
urologie
interested
dans
in
les patients
doing adult
comme
urology with
j'ai
us and take
je
care
savais
of
pas trop quoi faire au début,
complex cases with
puis
different
je
pathologies,
lui ai
and
posé la
people
question,
didn't
est-ce
really
que c'est
know
une
what to
possibilité
do,
de faire
and there was a
ça?
need for this. And I
Ben, sans
thought,
problème, c'était une
for
idée
sure, right away, I said, yes,
très
I'm
positive de
interested.
ça.
And at the time,
On était
very few
beaucoup
people were taking care of
on l'a fait de façon
this.
autonome. C'est comme ça que
I'm
la
one of the
clinique
first ones in Canada,
s'est
actually. This
installée.
is
Ma
how the
collègue Dr.
clinic
Jolivet a
appeared.
commencé à
And
travailler
then
dans le
Dr.
coin.
Jolivet
Puis petit à petit, on a
started to
commencé
work.
à ramener
We worked
à
together, and
Sainte-Justine. Puis
she works in
nous,
Saint
on a
Justine.
décidé
I
de
worked at the
combiner
CHUM.
la
So we have
plupart des
combined
patients
clinics.
Spina Bifida qui viennent au
And most
CHUM
of the patients, the
connaissent
Spina
Dr.
Bifida
Jolivet et moi.
patients, know
Puis
Dr.
ils
Jolivet and
avaient été à
myself.
Sainte-Justine avant de transiter vers le CHUM.
And they were at Saint Justine
C'est
before
le modèle qu'on
transiting
a
to the
mis
CHUM. So
en
this is the
place.
model we've put in
Évidemment,
place.
il y a des endroits où il n'y a qu'un seul urologue, mais
Some
je pense que
places have only one
il y
urologist
a plus
working, but I think we
que les
need
patients
models
acceptent
with
que les
more than
patients
one
ne soient pas
urologist. Patients need
partis
to
de
accept to work with more than one person, because if there's only one person
puis sortir
and this person for some reason is away or sick, or then we have a system that's problematic. And
Qu'est-ce qu'on fait comme
so what
suivi
do we do as
chez les
far as
patients
follow-up
deviennent
with
adultes? En fait, c'est beaucoup
patients
ce qu'on fait
who
chez
become adults? It actually looks quite
les
like what we do with
patients moins
kids.
actuels. Toujours
There's
savoir s'il y a des
at least a
changements,
follow-up every year.
puis
Sometimes it's every
avec
6 months if there are
l'examen physique,
changes.
on
So
fait
we'll
des
have a
bilans
physical
nutritionnels
exam. We
sur
will
tous les
do
calendriers de
mictional calendar, catheterization,
regarder
and we will
physique.
do a stool
Puis
schedule. We will
encore là, selon
also
la
look at
spécification
blood
de
tests and renal
reconstruction, on va peut-être
function. And this
changer
also varies depending on how
nos besoins. C'est pas systématique.
patients are
Chaque patient a des
have
patients
evolved.
qui
We will also do urine
nécessitent
analysis and
font du
culture.
cathétérisme ou font de
Some
l'hydrophiltration.
patients
Donc, leur culture
do
sera
mechanical
positive.
discharge, and
On
they
évite de traiter leurs infections urinaires, sauf quand elles sont
sometimes
symptomatiques.
they have
Parce qu'il y a beaucoup de
urinary
bactéries qui
infection,
stockent
but we
dans
don't
le site
always treat them
d'implantation.
unless they're problematic.
On fait des bilans urodynamiques.
And we
Autrement, les
also
gens, en fait,
do a urodynamic
les
assessment.
appareils d'urodynamie sont
Before
positionnés
it
dans
wasn't
les hôpitaux
done,
adultes. Donc, il y en a dans les hôpitaux plus
but
universitaires,
we would
plus
find them in
endroits.
more university
S'il y a des changements cliniques, par
hospitals,
exemple,
but
un
we do
patient
them if there are clinical or radiological
cathétérisme,
changes. If
pas
a patient was regular
de
with the
conception féminine,
catheterization,
commence à avoir de l'incontinence, puis
if there's incontinence
en
appearing,
visite, on se rend compte que c'est
and
peut-être
then
une
after
infection urinaire,
follow-up, we realize
on
it's
demande
not
changement,
urinary
observation,
infection, but there's a
puis
change in the
transport
behavior of
vers le
the
système
bladder. If
urogénital,
the
donc il n'y a pas eu de changement
patient
on
is
va faire
taking regularly medication, then we'll do a urodynamic assessment. If the bladder is degrading, then we will do a
et ou
treatment
améliorer
to protect
l'incontinence, puis retrouver une fonction
the
sexuelle
kidneys and
adéquate aux patients.
improve continence.
Bon, ici, je vous ai mis des modèles où on dit un peu
Here there are
étapes qu'on fait,
models
qu'est-ce qu'on préconise, parce que
where
vous allez
we
avoir
write our
c'est sur
criterias, what we
l'article que vous
follow.
allez avoir
It's
dans les
from
présentations.
articles you'll have in the
Là,
references at
évidemment,
the end.
beaucoup de nos patients
Of
ont
course,
aussi
many
sont
of our
très
patients
construits.
have
Plusieurs ont besoin de
bladders that are
reconstruction
not
ou de chirurgie.
rebuilt, or but
Les
many need
techniques
rebuilding or
hypoglycémiques
surgery.
chez les adultes
So when
sont
we think about when we have to think about that in
recommandables,
adulthood,
contrôlées, soit avec les
it's when
hydromédicaments,
there is
soit par
uncontrolled
des traitements
incontinence,
de vessie.
Loss of bladder compliance. Compliance means the ability of it to fill up with a low pressure. So we have urodynamic studies to measure this when there is the right pressure for the bladder. If it's too high, kidney filtration may be affected, and this is where you'll have issues. So we want compliance. If there is a loss of compliance, we think about doing surgery. If there is a deterioration of bladder function, of kidney function, it must be protected. Sometimes it's the patient's desire to get reconstruction, or if they have issues with bladder emptying and catheterization, if they can't complete it. In the past, people would use ducts, but now we try to find another solution. Now, we talked about transition quite a bit, so let's talk about fecal elimination. This is the point of view of a urologist who sees a lot of patients with issues with their stools. So there's two main problems that arise. So bowel incontinence or constipation. So irregular emptying of the bowels or not at all. So between this high constipation and incontinence, you have a whole spectrum. Sometimes people experience both, diarrhea, uncontrolled stools. So we have to help them reach a socially acceptable fecal elimination for them. So often the patients will tell us what is acceptable for them. It's not up to me or to other doctors. It's the patients that will tell us what is acceptable for them, and we will adjust treatments according to what they want. So what causes constipation or fecal incontinence? Many problems will affect people with spina bifida. Sometimes it's a slow intestinal transit because it has abnormal neurological signals. So the movement in the bowels is not the regular speed. Sometimes it's a sensory issue. Sometimes a patient does not receive the signal to the brain to let them know that they should go to the bathroom. Sometimes there's a problem with the sphincter that cannot be controlled. So sometimes they feel that they should go to the bathroom. They can't uh, uh, relax the sphincter to let the stool come out in a controlled way. Or sometimes the sphincter itself doesn't have tonus and it's completely open. So that causes fecal incontinence. So depending on the pressure on the abdomen, that it can be affected, but it's not something that is controlled by the patient. And sometimes it can be a mix of all these issues, many sensory issues, or combined with a good transit. However, so as the caretaker, I have to adjust with the patient to find the best recipe. So with fecal matter, it's the same as urine. It has to come out regularly. It can vary, but in general, for an adult, it's daily or every 2 days. In some situations, more than every 2 days is okay, but for others, it has to be every day. But the idea is that it has to be done in a controlled way. When a person decides that they have to go to the bathroom, they decide to go. So, regular fecal elimination, so it can vary, but every day or every 2 days is what we're aiming for, and a socially acceptable continence as defined by the patient. How do we reach this? Of course, the most important thing before any treatment is to make sure that we have a healthy diet with a good fiber and fluid intake. Many patients limit their fluid intake because they have a lot of urinary incontinence, so it's logical to do this, but in general we want them to have a good fluid intake to decrease urinary tract infections, and also it can cause constipation if there's not enough fluid intake. Same for people that don't have spina bifida. Sometimes these patients are less mobile, so that can be part of what causes their constipation and fecal issues. Sometimes we'll give them fiber supplements. It gives more volume to the stools, which makes the transit easier to control. Of course, we have to have a good elimination routine. We start this early with children. So the routine is to at least sit down every day at a regular hour. What we recommend is after dinner. Um, because after eating, this stimulates the bowel, so it's a good time to try to empty the bowel. For young children, the perineal or anal stimulation can help parents learn this. So a small massage on the perineal area will stimulate the rectum and will cause a contraction, and the stool will pass. Some patients, even if it's not frequent, will use rectal curing when we have physical limitations, or for young children, they can't do it themselves. So for children, parents do it. I have a patient with whom I'm working since 1991. She was a child when I started caring for her. I was a resident. Now she's in her 30s, and she's always used rectal curing, and there's never any stool leaking. She's just mobile enough to do it herself every day. When she was a child, her parents did it, but now she does it herself. So it can work very well for some patients, and no leakage for her. So it's not the most popular method, but you can think about that. She has no complications. So you just have to get over this idea of inserting your fingers and manipulating your stools, but it works pretty well. Then there's medication, pharmacological treatments. There's many categories. Some we use more for children and less for adults. So lubricating laxatives are more used for children, like mineral oil or a mineral oil jelly, which is called Lansoy. Works well for children, for babies that are still wear diapers. But if we use too much, it causes malabsorption and belly aches. For older children or adults, when you wipe After going to the bathroom, it's more difficult because there's oil, so it's more difficult to get cleaned up after. So patients don't like it because they feel like they're still dirty. So when they use mineral oil on a regular basis. Other laxatives, we have stimulating laxatives that have a chemical effect on intestinal function to increase the transit and stimulate the colon. There's many of them. The most popular nowadays is polyethylene glycol. There's many types, many brands. Laxaday is one, but many other companies create this medication. The idea is that not to cause a dependence. Many of them cause dependence. So if you use it in a chronic way, but with a neurogenic bladder with spina bifida patients, sometimes you don't have a choice. You have to release the stools in some ways. So they have to use medication in a chronic, regular way. We can't stop it after 2 or 3 months. When it works, they will take them as long as our treatment plan works. So laxaday is one of the ones that we use the most, very little side effects. But sometimes it's just the issue is just adjusting the dose to making the stools soft enough so they're evacuated, but not too soft so that it becomes diarrhea. Because with people that have issues with the sphincter can make the incontinence worse. We also have bisacodil, an oral medication, but that can also be a suppository. Can be useful. Milk of magnesia we don't use as much. Glycerin can be practical. It's an oral medication, but can be a suppository as well. It can be combined with other stimulants. It is a stimulant. For the rectum, it's a sugar that dissipates in the rectum and stimulates it a little. What's useful is that when we insert it, we know that in the next half hour, normally we'll have to pass a stool. So we can sit on the bathroom, on the toilet. It's easier than using polyethyl glycol. It softens stools, but does not always necessarily come out when the patient wants it to. Sine is a plant extract called also Senocot, is often used. Comes in many different forms, gel, capsule, syrup, very versatile. The only disadvantage is that it can cause cramps, stomach aches. So people with spina bifida sometimes have less sensory feelings, so it can affect them, but it's very useful.
After this, we can go with, we can also go through the mouth, but we can also use the intrarectal approach. It's not always easy, but when it's kids and parents are there, the manipulations can be done by the parents. But when we're an adult, it depends on how we are, and usually people want to be independent, and it really depends on the level of disability. Are they in a wheelchair? Can they do manipulation? do they have a manual limitation? So this is not for everybody because sometimes it requires to have help in order to use the intrarectal approach. A lot of the adults are not totally autonomous. They live in an autonomous way, but they have help at home. There's glycerin, the bisacodil, that's also a stimulant, can be used as a suppository, and it's can be combined with intrarectal stimulation. There's also enema. There, Microlax, it's very efficient. Now it's out of stock, but we hope it will come back. There's a little ampulla. It's a little bit like the fleet enema. We have them in pediatric or adult doses, and patients respond well to them. The advantage of enema, we decide when we do them. So we have a certain independence and we know when we will have a stool movement, intestinal movement, or so we can sit on the toilet. And when once we've eliminated part of the stools, and there's the patient knows that they can have a good period without risk of incontinence. Very often we combine these treatments. We can do enema and then take oral medication as well. We can take polyethylene glycol and maybe enema every 2 days and suppository every 2 days. So the recipe changes and varies depending on the patient, and sometimes it's trial and error, and it depends on the physiopathology of the a patient, and not all spina bifida are alike, right? So there's a whole spectrum of malformations, more or less severe. So we really adjust the treatment uh, according to the patient. So if we have oral medication and or if we see that something is not working, we can use more advanced methods. One of the most common is retrograde colonic irrigation. So we put the cannula in the rectum. Uh, there is one on the market that's called the peristine, and once it's in the rectum, we can pump water in the rectal part of the intestine, and then we can discharge part of this of the intestinal. So a lot of the patients who have done this will be 24 to 36 hours without having to do anything. So it's a big advantage because it's not really medication, it's partly mechanical. So it can be done by the patient, him or herself, with minimum of help. The pump to introduce the liquid can be controlled by manually, and the patient can be sitting on the toilet. So it's really easy to teach as well. So we have our nurses at Saint Justine and at the CHUM who can teach it to the patient the first times. And patients are really satisfied actually with this method. But for certain patients, it's not easy. Uh, and if they're taller, bigger, they cannot manipulate it easily. So there are other methods as well that we can use if peristine cannot be used or will not work. The two other methods that are significant, we've been using them for uh, many years. They're called Antigrade enema. So we uh, discharge the whole intestine. So there are two ways to do it. We can use a cecostomy button, or we can use Malone or Monti procedure. These are two variations of the same principle. So the Malone, we take the appendix on the and then we bring it to the skin at the appendix. It's a small surgery. And once this is branched to the plug to the skin, the patient can just do a catheterization. And most of the patients do it already with the bladder, so they're used to doing it. And the catheter is the same one. And they have a irrigation system that they plug to their catheter for 45 minutes. And we use a saline solution of up to 1 liter. And it can be made at home using tap water. Some people prefer to use boiled water, but it's not necessary. We can use tap water. That's perfectly fine. Usually, people do it in the evening. They sit on the toilet, and they within 45 minutes they can discharge the whole intestine. So the advantage of doing this in all integrity is that we since we discharge and the whole intestine, then we can go on for maybe almost 2 days without doing it. The cecostomy button, the second image here, has the advantage that it doesn't require surgery. It's done with radiology and imaging, so it's not as invasive, but it's a little button that's visible on the skin. Some patients don't like it. But when it's an appendix, we can put it in the belly button or in a way that it's not seen on the skin. But the two systems work very well. And it's the same principle for both of them. And they can be used for a long period. And it can be also combined with medication, irrigation. There are a lot of ways to empty the colon. For some patients who have a more severe disease, the uh, colon can deteriorate. Sometimes it can accumulate a lot and it can stretch out and expand, and it's not as functional. And sometimes we need to do a surgery to either shorten it, or sometimes for certain patients we have to empty the stools in a little bag. But that's really a minority of people. Most of the time, we can actually resolve the problem with all the methods I've illustrated in the slides. So this is pretty much what I wanted to say about the stools from point of view of a urologist who works with pediatrics and adults. As a conclusion, I'd like to say that the care of a patient with spina bifida is lifelong, and people now have a long life expectancy, almost the same as someone who has no disease. And we have to remember that bowel function and bladder can change throughout the life, and it's important to do regular checkups and follow-ups. So transition is actually an utmost importance in this regard. And of course, if we manage well stool elimination and urines, we have to do both, as you can imagine. We don't want to have a patient who is incontinent on the urinary level, but continent with stools. So we want to achieve reach a quality of life that's as optimal as possible, and give as much autonomy as possible to patients. Thank you very much.